Good morning everyone. Today my topic is about potassium disorders-Hypokalemia. It's a principal intracellular cation with more than 98% of body potassium found within the intracellular water. In the resting state, cell membrane conductance is higher from the potassium than sodium. Function is mainly used in the electrophysical cellular integrity, maintains resting membrane potential, generates action potential, excitation of cardiac tissue. Hypokalemia is basically less than 3.5 milliequivalents per liter, which is absolute, and it ranges from 2.2 to 2.5 milliequivalents per liter will cause muscular weakness, arrhythmia, electrocardiac abnormalities will be seen in the ECGs. Most common causes reduced intake. Potassium shifts from the extracellular to the intracellular fluid, mainly caused due to excess insulin, either in the exogenous or endogenous, beta adrenergic agonists such as endogenous catecholamines or exogenous salbutamol, acute rise in plasma pH. Vomiting, this is not caused by loss of potassium in the vomit, rather than loss of potassium and water lead to metabolic alkalosis and increase in aldosterone. Excessive renal losses of potassium with excess of mineralocorticoid or diuretics. In gastrointestinal losses. And clinical manifestation, hypokalemia can produce widespread organ dysfunction, cardiovascular effect are most prominent and include an abnormal ECG, arrhythmias, decreased cardiac contractility and labile arterial blood pressure due to autonomic dysfunction. Skeletal muscle weakness also will occur. The ECG changes mainly T-wave flattening and inversion and increase in prominent. U-wave ST segment depression, increased P-wave amplitude and prolongation of PRQ interval, increased myocardial cell automaticity and delayed repolarization promote both atrial and ventricular arrhythmias. This is the ECG pattern. Treatment mainly involves depends on the presence of severity of any associated organ dysfunction. Oral replacement of potassium chloride solution is generally safest, 60 to 80 milliequivalents per day. And replacement of potassium deficit usually requires several days. Peripheral potassium chloride intravenous replacement should be exceed 8 milliequivalents per hour by the irritative effect of potassium on peripheral veins. Anesthetic consideration is the decision to proceed with elective surgery is often arbitrarily based on lower limit somewhere between 3 to 3.5 milliequivalents per liter. The decision should be based on the rate at which the hypokalemia developed as well as the presence or absence of secondary organ dysfunction. And intraoperative potassium should be given if atrial or ventricular arrhythmias develop. Faster intravenous replacement 10 to 20 milliequivalents per hour requires a central venous catheter and close monitoring of ECG. And intraoperative management of hypokalemia requires vigilant ECG monitoring. Dextrose containing fluid should be avoided because this will cause hyperglycemia and secondary insulin secretion may actually lower the potassium even further. And glucose-free intravenous solution should be used. Hyperventilation avoids to prevent further decrease in plasma potassium. Increase sensitivity to neuromuscular blocking agent. Dosage of NMBs receptors blockers should be therefore be reduced 25 to 50%, and a nerve stimulator should be used to follow degree of paralysis and the adequacy of reversal. Thank you.